for keeping on time. Thanks a lot.
Yes.
Very informative. Yes, yes, very well done. Thank you very much. We will move on to the next talk by Dr. Khaldoon Alaswad, who is a guru of CTO. He's the director of the Cardiac Catheterization Lab, Henry Ford Hospital. Dr. Khaldoon Alaswad, on your talk on step-by-step planning and performing CTO PCI. Dr. Khaldoon.
Thank you so much for inviting me, Dr. Malik. I really appreciate it, and thanks to Dr. Basir for this opportunity. I think this second time I give a talk in Pakistan virtually, and I love the opportunity. I feel honored. Eid Mubarak to everybody, belated Eid Mubarak. Do you guys see my presentation?
Not yet.
Yes.
If you can screen share.
Okay,
yeah, we can see it.
I'm sharing it. I'm going to stop sharing and I'm going to share again.
We can see it.
Okay. How about now?
Yes, we can see it.
All right, perfect. So this is my task today is to talk about CTO PCI step by step, which is a really very large task, but I'll try to make it as brief as possible. These are my disclosures. And this is basically the outline of my talk. If you want to do CTO PCI, there are 3 stages. As my friend Salman Arain says, there are 3 stages. And I think there are 3 stages for everything: patient selection, preparing for the procedure, and then performing the procedure. And each stage has to be approached really thoughtfully. And you cannot really cut corners when you're doing CTO PCI. So about the patient selection, you have to remember that patients actually do benefit from CTO PCI. And this is the ischemia trial, showed the quality of life improvement with an invasive strategy. And that cannot apply any more than in CTO patient, because the symptomatic ones are actually who benefit the most from revascularization. And of course, there is an argument for complete revascularization in the STEMI population, in non-STEMI population from this study. And this is from 57,000 patients from the VA. The complete revascularization clearly did better in MACE and even death. And you have to remember, our VA system here, it's like a public health. So there is no exuberance in the practices here, and people clearly benefit from complete revascularization. So if you want to think about doing CTO PCI, there are multiple things you have to kind of be prepared for. The day of the procedure, you have to think about yourself as the pilot. I recently learned how to fly planes, and I learned that if you want to fly a plane, all your training is about safety. And there are something in airplane preparation and prepare to fly is something you have to check yourself as a pilot. So you have to check yourself as a CTO operator, and these are the things which you have to check yourself for. In the day of the procedure, like I'm safe. I for illness, medical. If you took Benadryl that day, you shouldn't really operate on patient. If you are stressed out, you have a big fight with your spouse, you shouldn't really kind of operate on patient. Of course, alcohol in America plays a big role. You should not drink alcohol within, in the pilot world, they say bottle to throttle 8 hours. And I think the same applies for interventional cardiology if people drink alcohol. Fatigue and being actually hungry and not eating also it affect your judgment, as these are very complex procedure. You need to be on your game. And then you have to bring your skills and skill sets. So I like to kind of talk to the interventional cardiology community and remind them what happened in the pilot's world. To fly the biggest Boeing airplane, 787, you really have to get into vigorous training. You have to log so many hours in lesser airplanes. In addition to that, pilots not only get like one-time testing, they get board certification and they have a license to operate. They actually have to go back, retrain every 2 years. and they have to be checked. And in fact, commercial pilots in America, I think they have to be checked every year, and their medical exams, and there are rigorous testing, and they go to the simulation, and someone will observe them. In interventional cardiology, and it's actually, we don't do any of that. We basically give a license to someone and you operate. So Scott Hardings and his colleagues from Asia Pacific put this really very simple scheme. It is, if you do coronary angiography and you kind of classify this CTO, hard CTO, you really should kind of call the expert to come and help you, or send the patient to the expert. If it's less than a hard CTO, you definitely can try doing the CTO PCI. But CTO PCI, it's became really kind of the preview of expert or high-end experts in interventional cardiology. So not everybody should do this procedure for obvious reasons. So we'll talk about some kind of tricks. How you do the angiogram is different when you do it for CTO PCI versus non-CTO PCI. This patient on the left here, you can understand where this graft is going. So there is a graft going to something in the inferior wall, and it turned out, unless you do dual injecting, it turned out that inferior wall is not a PDA from the RCA. This patient was sent to me to open the RCA CTO. This actually inferior branch on the left actually belongs to the LAD, and the SVG was diseased in there. So performing angiography is the first step of performing CTO PCI. You really have to be very meticulous. And when you do the angiography, you should lower the mag a little bit so you can see the entire heart and do not pan. So these skills are very important for everybody who's doing angiography. And there are a lot of old habits, like I used to do that, well, magging so much and chasing the contrast. That does not give you a global picture of what's happening in front of you. So lower the mag a little bit until you put the whole heart, and then you kind of do the angiogram with no panning. And you will be able to see the collaterals from that. So when you look at the angiogram, what the information you need? You need to ask about the proximal cab, the target, and if you have an intervention on collaterals or collaterals you can cross, then the length of the occlusion become actually somehow important. And this comes from the hybrid algorithm. However, when you approach in CTO PCI, you really have to have a plan. You have to have planned out in your head what you're going to do, first step, second step, third step, and when you're going to fail. If you think that way, you actually guarantee success more than failure. And there are multiple schemes kind of developed. This is the first one called the hybrid. There is CTO Club China. There is actually a little bit of kind of confusion in these. Like in here, there is above 20 and less than 20, and there are double negative. So it's really more confusing. In the Euro CTO Club, they actually have an obsolete thing, no crossbus. Nobody uses a crossbus anymore in the ADR. In the Asia Pacific CTO, there are also still kind of emphasis on no crossbus. So what Brilakis and his colleague did, they actually gathered about 70 to 100 interventional cardiologists, and they developed the global algorithm, which is the reference there. And I think it's a very good guide for doing CTO PCI. However, the global algorithm is not good enough. You have to think about each problem you're going to face. And once you face it, like you're wired with the cross, but nothing will follow. You cannot actually solve them. You cannot tell where the proximal cab. So there are algorithms in the algorithm. And I'll leave you with Robert Riley paper to kind of go over these things. But these are actually gained with experience. Also, when you do CTO PCI, there are now algorithms to predict the complication rate. So this is from the Progress Registry, and you can actually see multiple. There is one for mortality, one for pericardiocentesis or needing pericardiocentesis, but this is in general for MACE. So a patient above 65, female sex, calcification, and ambiguous proximal cab, and antegrade dissection reentry or retrograde, they all expose the patient to higher risk. So you really have to look for these things before you start. And before you plan your strategy so you can know what to do. So skills and skill sets. Antegrade wiring is actually simple. Wire choices, microcatheter, and escalation. And Salman talked about this really nicely. I wouldn't dwell on this, but you have to think about, like, limit the number of wire you choose. And this is basically the general algorithm. Polymer jacketed taper tip, low gram tip wire. Start with that almost every time after the workhorse wire. Should put the workhorse wire on the top. If you know the anatomy, you can actually stab. If you don't know the anatomy, you should stick to polymer jacketed wire, and you can increase the gram. The polymer jacketed wires do not perforate that easy unless you take a small side branch.
We have one more minute.
The next skill set is going to integrate dissection re-entry. It's very important to develop how to start the knuckle, protect the subintimal space, advance the knuckle, and then perform the re-entry. And there are multiple ways you can do that. So, sorry about that. The retrograde, there are actually longer steps. You actually spend 1 hour extra every time you go retrograde. You increase the procedure time by 1 hour. You have to select your collaterals crossing, microcatheter crossing, making the connection, wire externalization, and finishing. So in general, these skills, you should kind of symbiotically put them together to solve the issue, and you move forward with the procedure. The philosophy is when you are a CTO PCI, you should basically proceed with CTO PCI if there are clinical indication, not because of the anatomic difficulty. You should tell the patient, you need a revascularization. If you can do it, you can. If you can't, you send them to someone else who could. The anatomy only dictates the strategy, how to open it. The most important thing, and even now, after so many years of doing this, I have to remind myself I should not get stuck in a failure mode. If a strategy does not produce results in 5 minutes, you should stop and change it. And if you know all the skills we talked about, you can actually change and recycle through them. And I would like to call these the fundamentals of successful CTO PCI, and these are what I teach the fellow. So first of all, stand on a really solid ground. Large sheath, large guides, and very supportive guide. Maximize your knowledge about what the CTO do angiography, do CT, do IVUS, so you can actually know what's happening. Never perform CTO PCI without a microcatheter. That became an obvious. Never stab blindly. If you do not know the anatomy, do not go with a pokey wire. The knuckle is always safe to go around, and I will show you a picture why the knuckle is safe. Verify wire position before you advance anything. So this wire went retrograde through epicardial collaterals, you inject and you see the wire going into the PD. Then you advance a microcatheter or a balloon or whatever. Never rule out any option. This is no view here, like we were able to cross this collateral. This is like mediocritus, meh, good enough. That should not be your mode. Push yourself, but do not be fools. You should always strive to learn. This is a picture on the left. The IVUS showing the knuckle, actually how the knuckle does not exit the adventitia, only if you push it in a small branch. So always trust the knuckle. Complication management is very important. You have to be familiar with coils, and this is the algorithm how to approach it. Remember, do not reverse before you take your gear out. Do not reverse the heparin before you take your gear out. You should have your complication gear available to you all the time. And the most important thing, be expert in intravascular imaging. Studies shows that you actually have a better outcome regardless of what you're doing. This is a patient. You look here, we were able to solve this with a simple IVUS. We can see the wire in the proximal cab, and we solved it, and we got taken care of this LAD. In summary, CTO PCI is still indicated. There is a steep learning curve. CTO PCI is still complex, and previously I used to say, and higher risk procedure. However, if you look here, this is from a progress registry, the overall complication rate. This is overall 1.6 in 2022, and at my hospital is 1%. I like to brag about that to everybody. And this is basically because of all these skills and techniques and approach and papers we published on approaching CTO PCI. So you can achieve lower risk than regular PCI if you are expert in this. Thank you so much for inviting me, and I'm looking forward to seeing you all.
Thank you very much, Dr. Khaldoon Alaswad. We will look forward to seeing you in the HORM.